dear moderator and dear colleagues. Recommendations for the management of acute liver failure have been edited by the American Association for the Study of Liver Disease, and these are the definitions used for assessing the quality of evidence. As Julia Wenden told us, paracetamol remains the major etiology of acute liver failure. And 26 years ago, a prospective randomized control demonstrated a benefit of acetylcysteine for the treatment of paracetamol-induced fulminant hepatic failure. And in this trial, more patients survived with acetylcysteine. 25 years later, a meta-analysis confirmed the same results. So NAC should be used as soon as possible for paracetamol-related acute liver failure. The reference protocol is 150 milligram per kilogram over 15 minutes, then 50 milligram per kilogram over 4 hours, and then 100 milligram per kilogram over 16 hours. 16 hours, yes. But there are other regimens. You can use the oral route, or you can administer the loading dose on a more prolonged time, or use higher total dose over 48 or 72 hours. So in most cases, you need to treat more than one day, and when to stop is controversial. It's generally recommended to continue NAC until substantial improvement, which means clinical improvement and improvement of coagulopathy. NAC should be used irrespective of the dose of paracetamol and the delay of ingestion. And we should keep in mind that paracetamol ingestion can be unrecognized and finally be the cause of so-called indeterminate acute liver failure. For non-paracetamol acute liver failure, randomized controlled trials has also shown a benefit on transplant-free survival at 21 days. So this trial was designed to detect unilateral difference, and the effect was prominent for patients with grade 1 and 2 hepatic encephalopathy, but not for those with grade 3 to 4. When looking at the various etiologies in this study, the effect was also prominent for DILI, which is drug-induced liver injury, HBV, indeterminate hepatitis, but not for autoimmune hepatitis. There are specific therapies for specific etiologies in acute liver failure. For hepatitis B, 2 recent nucleoside analog, entecavir and tenofovir, should be considered in the treatment of the patients. And one of the reasons is probably the prevention of post-transplant recurrence. This is a grade 3 recommendation. For HSV or VZV etiology, the treatment is a cyclovir or foscarnet, and of course there is no randomized control trial. Cytomegalovirus is a very rare cause of acute liver failure, and the treatment, as everybody knows, would be ganciclovir or foscarnet. What about amatoxin-containing mushroom intoxication? So 2 treatments can be proposed. Penicillin J at a high dose, 0.3 to 1 million units per kilogram per day, and or silibinin or its derivative silimarin when it's available, because it's not available in every country. Autoimmune hepatitis, normally the treatment is corticosteroid. It should be given at the earliest stage of the disease at the dose of 40 to 60 milligrams per day. But there is a high risk of infection, and this may be a problem at the time of liver transplantation later. For Wilson, disease, one of the aspects of the treatment is to lower copper concentration. This can be made with mass dialysis or continuous veno-venous hemodiafiltration filtration or plasma exchange, but there is no grading for such a recommendation. For Budd-Chiari syndrome, the treatment is anticoagulation. But from the literature data, there is a high and rather unusual rate of heparin-induced thrombocytopenia. So unfractionated heparin is no more the anticoagulant of choice, and low molecular weight heparin should be preferred when possible, and sometimes danaparoid. Tips should be also made when in selected patients when it is feasible. For acute fatty liver pregnancy or HELP syndrome, expeditious delivery of the infant is the recommendation. And malignancy, the rare cause of acute liver failure, approximately 1% of etiologies in large series. Chemotherapy is rarely feasible. However, in some cases, well, the two main etiologies are breast cancers and the second is lymphoma. And liver transplantation have been proposed, rapidly followed by chemotherapy in some cases of patients with lymphoma, and these have been successful in some cases. How to treat hyperammonemia? Lactulose can be used, but the efficacy has not been demonstrated in the setting of acute liver failure. Seizures should be treated with short half-life benzodiazepine, phenytoin, or barbiturates. Unfortunately, neurological assessment is not possible with the use of barbiturates for a long period of time. There is no benefit of prophylactic phenytoin. Now, what about intracranial hypertension? It can be imaged with brain CT scan or magnetic resonance imaging, sometimes magnetic resonance spectroscopy. Transcranial Doppler have been used, and by assessing the velocity time waveform, it permits indirect assessment of intracranial pressure and cerebral perfusion pressure. Controversy continues to rage about the use of invasive transducers to monitor intracranial pressure. I think that it should be done only in centers with a high expertise in ICP monitoring. The treatment of suspected or measured elevated intracranial pressure relies on, this is classical, mannitol, this is a grade 2 recommendation, sodium chloride with a targeted natremia of approximately 150. Barbiturate could be used in the case of refractory intracranial hypertension, but no corticosteroid for this reason. What about hypothermia? It has been proposed for the management of intracranial hypertension, but the degree of evidence has declined with time. In this recent publication, 46 patients were allocated to receive moderate hypothermia, targeted temperature 34, or control. In this figure, you see the actual temperature reached in each group, which was quite different. Unfortunately, in the table, there was no difference either in intracranial pressure between groups or in survival, whether patients were transplanted or not. So finally, the conclusion is there is no need for routine use of hypothermia in this setting. Patients who progress to high-grade hepatic encephalopathy should be intubated. Sedation should be reduced at the minimum, and hyperventilation should not be fully inhibited unless ERS is present. For hemodynamic fluid resuscitation is with normal saline. This is a grade 3 recommendation. For vasopressin, norepinephrine is preferred. Vasopressin and terlipressin can be used, but may favor intracranial hypertension. So probably you should prefer norepinephrine as the first agent. The use of hydrocortisone or fluorocortisone or hypotensive patients after the stenectine test is reasonable, but not proven in this patient. The goals of circulatory support have not been well defined in these studies. Nevertheless, the AASLD recommendations give a mean arterial pressure of 75 millimeters of mercury and a cerebral perfusion pressure of 60 to 80 millimeters of mercury. And for acute kidney injury requiring renal replacement therapy, you should prefer continuous rather than intermittent modalities. The prevention of infection, the role of antimicrobial prophylaxis is controversial. One trial, an old trial, showed a reduction in the rate of infection. A more recent retrospective study showed no difference on bloodstream infection. In the absence of an evidence base to guide practice, early preemptive antimicrobial therapy seems reasonable in patients with progressing hepatic encephalopathy, in those with progressing coagulopathy or organ dysfunction, or in those with positive surveillance culture. Nutrition has not been specifically assessed. No severe protein restriction is needed. Approximately 60 grams per day is appropriate in most cases. You also have to prevent hypoglycemia, and you don't give insulin therapy. Enteral feeding should be given, especially in patients who are intubated and have a nasogastric tube. Bleeding prevention, prophylactic administration of fresh frozen plasma is not recommended. Thrombocytopenia can be maintained until 10 or 20 giga per liter because finally spontaneous bleeding is not so frequent. Replacement therapy for thrombocytopenia or prolonged prothrombin time in the setting of is recommended only in the setting of hemorrhage or prior to invasive procedure. So recently, trials showed important benefits on mortality, survival, calculated at transplant sensor survival with the use of high-volume plasma exchange. You can see on the curve that the benefit is important. I did not especially focus my talk on this point because I think that maybe it will be detailed in the last communication by Julia Wendell. So my conclusion is that patients with acute liver failure should be managed in centers with an active liver transplantation program and with expertise in caring for such patients. N-acetylcysteine should be early and universally used. Specific therapies depend on particular etiologies. And finally, general ICU management with appropriate support of multiple non-liver dysfunctions is crucial for the outcome. I thank you for your attention.